Hello and welcome to another episode of the Pikeville Medical Center Specialty Spotlight. I'm your host, Carly Lambert, and today I'm joined by PMC physiatrist Dr. Charuma Milla and IPR supervisor Sabrina Martin. How are you all today?
Doing great.
Thank you all so much for joining us. So, these everyday activities that people perform, we don't think much of it until we have trouble doing it. And that's what IPR or inpatient rehab can help with, the healing process of that. So let's talk a little bit about what inpatient rehab is and how does it differ from other rehab and therapy programs?
Inpatient rehab, this is actually referred to as inpatient rehab, but it's basically a post-acute care. So patients, our patients come from our hospital, acute care, for whatever reason, different reasons. They get strokes, brain injuries, spinal cord injuries, cardiac problems, pulmonary reasons, whatever reasons. Even a few days of being in the bed can cause a lot of debility, and they lose a lot of function, muscle strength. So that's when the post-acute care comes in. Our rehab differs in other types of post-acute care settings in the terms of intensity and the requirements set by the Medicare. So inpatient rehab, we're required to do minimum of 3 hours a day or 15 hours a week total of therapy, including at least two modalities, including physical therapy, occupational therapy, or sometimes they may need a speech therapy. Other rehabs, in other words, skilled nursing facilities, or if they go home health or outpatient therapy, they're not required to do this much intensity. They do at a lower level. And we have more resources. We have 24/7 physician availability, nursing availability, and we do therapy almost every single day to fit that criteria set by the Medicare. Skilled nursing facilities, they don't have that much resources. But it also goes deeper into that. We also look into whether the patient can tolerate this much of therapy. We look into other minute factors that skilled nursing facilities may not look into.
Awesome. So, it sounds like these patients are really getting a one-on-one kind of go with the therapist. And I know you mentioned stroke, some spinal injuries. So talk about some of the medical conditions that may result in an inpatient rehab stay.
So to give you a very technical answer, Medicare has set a 60-40 rule. That means that the rehab patients we admit have to fall under the 60% of the set diagnosis. Most of the major diagnoses we admit include strokes, any type of stroke, whether it's a bleeding type or ischemic type. We have patients come with a brain injury, either traumatic brain injury or non-traumatic brain injuries, spinal cord injuries, either traumatic or non-traumatic. These are the major. Other diagnoses include patients who fell and broke their hips, broke their ankles, shoulders, patients who have heart failure, other cardiac problems, or patients who have COPD, other lung issues, patients who lost their limbs from whatever reason, amputees. These are the major diagnoses we admit. Rarely we do have pediatric patients, extremely rare. In the last 7-8 years, I can think of maybe 2 or 3 patients. But there is a specific pediatric rehab setting, but we focus mainly on the adult rehabilitation, geriatric rehab.
Yeah, so it's really getting them back to their everyday lives, helping them do the things that they are restricted on doing because of their injuries. So talk about what a stay might look like for a specific patient.
Well, like you said, we offer physical therapy, occupational, and speech therapy. So we divide out their time, the 3 hours, depending on what they need, more of PT, OT, or speech. And we schedule them depending on what their needs are. So like if they need to do some of their ADLs, their activities of daily living with occupational therapy, which would include bathing, dressing, grooming, those types of things, they may want to see them in the morning so that they can get them up and get them going. They also look at their ability to feed themselves. You know, just being able to hold your fork, you know, your knife, your spoon, you know, things like that, that, like you said, we take for granted. You know, we're going, you know, to the bathroom, you know, being able to adjust your clothing and things. So they may see them in the morning. We usually try to split their time up so that we're not overloading them too much. So they may get, say, 90 minutes with occupational therapy in the morning, then physical therapy, we'll see them in the afternoon for their 90 minutes. You know, physical therapy, you know, we work on them getting in and out of the bed. Their transfers from the bed to a chair, they're walking up steps, getting into a vehicle. We have all of those types of equipment that we can practice all of that stuff with them up on our floor. And we try to simulate as much as we can with the patients to, you know, be able to demonstrate to them, you know, what they're able to do back at home. And then speech therapy kind of fits in, you know, in different areas. They'll see them, say, 30 minutes, 60 minutes, depending on what their needs are, as well, whether they're working on cognition, feeding, speech, you know, different things like that. So we do offer the therapy 7 days a week. And we follow the guidelines on what their needs are, depending on, you know, 3 hours a day, 5 days a week, or extending that out for the 7 days a week. And but we want them to be able to do therapy pretty much every day, even if it's not the full 3 hours, say on the weekend, if they don't actually have to have their 3 hours that day. We still want them to get up. We still want them to exercise. We still want them to walk, you know, things like that. So that's pretty much how a day goes.
So it sounds like a lot goes back into this rehab program, and you kind of touched on it a little bit, but we have a lot of variety of professionals, so different therapists, physicians, social workers. So touch on that team experience that you all have in forming a treatment plan for a patient.
Well, the physician admits the patients, and they go in and do their admission screening and stuff, and they write their orders and things. Nursing follows with that as well. There's pre-admission screening as well before the patient's even admitted onto the floor. And then the therapy comes into play, and we set up our treatment plans and things. But we work together for the patient as a whole, you know, with the physicians, the nurses, the therapist, the social worker, to make sure that we offer exactly what the patients need to get them back home is our goal, working together. And we work closely with the physicians, making sure they know how they're responding to therapies. We work closely with nursing, talking to them about what their blood pressure is, you know, if they're feeling bad today. Same with the physicians, you know, so that they know maybe how to adjust medications or whatever. We work closely with our social worker to make sure, because from therapy, you know, we're with them a lot. You know, 90 minutes every day is a lot of time. You get to talk with the patients. You get to know them. You get to know what their home environment's like, who their support system is at home, and so we make sure to plan, you know, those things with the social worker so that we get all of their appointments and things set up with them. We work with the families to come in and do education and training. Prior to their discharge, we have team conferences. We do those twice a week, and that's all of the disciplines getting together and talking about the patients, as well as talking with the families, so that we try to make sure that we're open communication with them so that they know, you know, what's going on, and planning for their discharge.
To add on that, it definitely rehab, you know, physical medicine rehab, inpatient rehab is definitely a team approach. You know, it begins with the acute care. To be honest with you, the team in acute care do a fantastic job making the patient stable enough to come to the rehab. They identify first and foremost that the patient needs rehab. Then they contact us. Our coordinator goes in and evaluates the patient, and then presents it to me, or I review it, and then based on that, you know, I make a decision whether to bring the patient, me means physician, or if something needs to be done, we, you know, communicate that with the primary care primary team, and they fix that and they bring the patient back. While, like Sabrina said, while patient is on the rehab floor, this is definitely a team approach. I need input from every single member in the team. That includes nursing, physical therapy, occupational therapy. That includes speech therapy. Family is part of the team as well. We just cannot ignore the fact how important the family and the patient are. Those are the main players in rehab progress. Social worker plays a significant role in getting the patient everything what they need when the patient goes home. We also include sometimes, actually not sometimes, a lot of times other specialties that are involved in patient's care, because sometimes the level of expertise is beyond the level of expertise by a rehab physician. That's when we reach out to the other specialties, and the PMC has a very good, we are very fortunate, our rehab is fortunate to have specialties available to help us to get the patient back to home or society. So definitely a team approach.
Yeah, absolutely. And a team approach is really what is going to elevate that care for a patient.
Yes, absolutely.
So on average, how long would a typical patient stay on the unit?
So on average, the length of stay depends on the diagnosis and also depends on the insurance and how good they are when they come to the rehab. If they are requiring a lot of help by one person or two person to do everything, even to turn in the bed, that requires them to stay. Actually, that gives them the little longer stay. If they have strokes, they get a little longer stay. So to give you a ballpark, anywhere between a week, 2 weeks, and 3 weeks. So 3 weeks is the maximum we ever had. Extremely rarely, insurances lets the patient stay a little longer, depends on their functional level. And we have to show the insurance companies that we are making progress, we're making goals, we're meeting goals, and our ultimate goal is to get the patient back to home.
So, 2-3 weeks, 3 hours a day, that's a lot of patient contact.
Absolutely.
And that's one-on-one time with the therapist and the patient. So I'm sure that builds a lot of rapport with your patients. So talk about that kind of relationship that you build with your patients.
So as a physician, I'll talk about the relation I build with my patient, and Sabrina can jump in. So this is one of the specialties. You make a relation with the patient from the beginning of the admission until the end. We only, every rehab hospital is different. In our rehab hospital, it's just me and Dr. Kalima. So they're going to see only two physicians, either myself or Dr. Kalima. When I'm on days off, they're going to see Dr. Kalima. So it's hard to miss. It's hard to not have that communication or miss any communication. At the same time, it's just the same goes with the therapy team as well. They're going to see me or Dr. Kalima. And as the same goes with the family, they're going to see me or Dr. Kalima. So the relationship that we build with patient is very important. It actually builds the trust between the patients and families and the physicians and the caregivers. In fact, they spend more time than I do with the patients. So,
yeah, definitely you build a great relationship with the patients. Like I said, you get to really know them, know their history. Some of their stories that they tell is just amazing. We've had veterans, that have fought in wars, and things. And I said, if I would have started years ago when I first became a therapist and wrote down some of their stories, it would have just been a neat book to have because you build that kind of relationship with them. And, like I said, we're with them every day, hour and a half a day, if not more. They become kind of like, part of our little family, and stuff. And we have a lot of patients that come back by to, see us, say hello, and thank us, for all that we did for them. And it's one of the reasons that I love rehab is because you get to build that with your patients.
Yeah, and I'm sure those patients are very grateful for what you do for them because you're helping them get back to their lives and, live a normal life that they were used to. So And I feel like a lot of people may not realize that we have an inpatient rehab at our hospital at Pikeville Medical Center. So talk about how our inpatient rehab may compare to, some of these hospitals in Lexington or Charleston.
So, our rehab hospital, like I mentioned earlier, our rehab hospital is different. We're part of PMC. We're part of the building, the structure. That's a good thing. The reason because we have the luxury of picking the phone and calling any specialty we need, and patients don't have to transfer out by ambulance to get a simple test like CT scan, MRI. If we need something, they're there. Other rehabs are different in those situations. For example, I did my training at Cardinal Hill. It's a great hospital, but the difference between Cardinal Hill, which is a standalone rehab hospital, and our hospital is we have the resources, everything we need in our building. They don't have to travel anywhere else. We know all the specialists. We know all the physicians who are sending to me. Bigger hospitals, the problem with the bigger hospitals is sometimes these things get lost. If you want to pick up, call someone, like for example, if you want to talk to a neurosurgeon, we don't know who the other person is. You may never have seen this person, which is rare, but that can happen. That's the few things I can think of. Our team is small, but it's not insignificant. So we know everybody in the team. The team knows who the physician is. Team knows about the physician, how they practice, how they work with the patient. So it's and they accommodate those things. Bigger hospitals, it's very not easy as us to accommodate, know the physician, their style of practice. So
I'll say with that as well as at Pikeville Medical Center, they have offered us so much equipment. I feel like we have the opportunity to have state-of-the-art equipment just as any other facilities have. And so that's, one thing that we offer here as well.
And ours is a very comprehensive rehab team. And within the 2-hour driving distance, I think we are one of the better, good rehab hospitals. I know there are other rehab hospitals within the driving distance, but I've seen that patients like us. So that tells something.
Yeah, and absolutely. Just by talking to you all, I can tell that you're passionate about your practice and you take really good care of your patients. So thank you so much for joining me today. It was really insightful, and I hope our viewers thought so as well. So thank you all so much for watching, and tune in next time for another PMC Specialty Spotlight.